6 causes of ST elevation on ECG. And as we discussed, if there's no left bundle branch block or LBH, the criteria for ST elevation MI in all leads is more than 1 millimeter elevation, except V2, V3, because you may find normally some ST elevation there. And in male less than 40, the criteria is more than 2.5, more than 42 and less than 40, 2.5. In females, in general, it's the same 1.5 millimeters. The localization of acute MI, if it's anterior, it depends on V1, V2 is septal, anterior 3-4, anteroseptal from 1 to 4, anterolateral V3 to V6 plus 1 and AVL, and if it's extensive, it involves all the leads from V1 to V6 plus 1 and AVL. And remember that LAD occlusion may present like bundle branch block with anterior fascicular block. For a lateral MI, usually it's due to D1 occlusion, but it may occur with OM or Ramus intermediate. And you will find that there's ST elevation in lead 1, AVL, V5, and V6, with reciprocal ST depression in 3 and AVF. If it's isolated high lateral MI, you will find ST elevation in 1 and AVL only, with ST depression in the inferior leads. If it's anterolateral, or D1 variant, you will find some ST elevation and upright T wave. Leads, still it's high lateral MI, and you will find reciprocal changes in the inferior leads. For the inferior MI, the RCA is the cause in 80%, and you will find ST elevation in 3 more than 2, with reciprocal changes in lead 1. If it's the circumflex, it's around 20%, and you will find the ST elevation in 2 and 3 are equal. Type 3 LAD, you will find anterior ST elevation plus inferior. For isolated posterior MI, you will find ST depression, tall R, and T wave in V1 to V3, and the R to S ratio in V2 will be more than 1. Again, you will find ST elevation in V7 to 9, and the more accurate is 1 millimeter rather than 0.5 millimeter. It's usually due to CIRC or RCA PDA occlusion. For RVMI, it occurs in 1/3 of inferior wall MI, and you will find ST elevation in V1, V2, any of these. ST elevation in V1 with ST depression in V2, or you may find ST segment isoelectric in V1 and marked ST depression in V2. Sometimes you will find ST depression in V1 and V2, and the difference from posterior MI is that there is no tall R wave in V2, because both can give you the same picture in V1 and V2. Okay, why it's not moving? Again, this is for isolated posterior wall MI. You will find that there's horizontal or flat ST depression in V2. The R wave will be tall and broad, and there's upright T wave with dominant R wave with R to S more than 1. Okay, again, this is another example of posterior wall MI, and you will find, if you reverse the V2, it will look like ST elevation. Again, for left bundle branch block, we discussed the Sgarbosa criteria, and you look deviation more than 5 millimeters, and you need a score more than 5 to diagnose MI in these patients. For the modified, it's the same criteria, but the third criteria will be 25% of the R or S wave, the ST deviation. It has high sensitivity and specificity compared to Sgarbosa criteria, and we've discussed this algorithm for diagnosing MI in left bundle branch block. As we discussed, right bundle branch block does not interfere with ST segment, so you can easily diagnose ST elevation MI in right bundle branch block. For ST elevation in AVR with diffuse ST depression, it may be due to left main or left main equivalent, and remember that this is only in 10% of patients. Proximal or OCL LAD, three-vessel disease, and the most common cause is usually subendocardial ischemia or type 2 MI due to other causes. We also came across the dual T wave, which is upsloping ST depression with beaked dagger-shaped T wave, and it's most prominent in V3. There may be ST elevation in AVR or AVL. And remember this shape, because it always looks like that, the Duinter syndrome. Williams syndrome, there are two types. Type A, in which there is biphasic T wave, and it's only 25% of cases, and type B, where there is deep symmetrical T waves in the chest leads. Okay, for LVH, there are criteria, as we discussed previously in the algorithm, and this is the lambda shape or the shark fin ECG, which is very high risk MI. To differentiate acute pericarditis from ST elevation MI, we already discussed what to look for, including the ST segment shape, which is smiley face in myopericarditis, while it's frowny face in MI, plus BR depression. The Spodek sign, we already discussed it. And ST depression in AVL is always absent in pericarditis while it's present in MI. Again, we discussed early repolarization and the changes in MI and early repolarization. And I think the most important is to look at the J-point notching or slurring of the J-point. So let's go to the ECG. Please, I need you one by one to read the ECG, please. Yalla, we start with you, Doctora. What do you see here?
Okay, can I comment?
Yes, sure.
Yeah, this is sinus rhythm with an ST elevation from V1 to V4, and ST depression in lead 2 and 3 and AVF, and ST elevation also in lead 1 and AVL. So this is most likely extensive anterior MI.
Exactly, and again, you know, notice that there's Q wave in V1 and V2. Usually, you don't see a Q wave in these leads. So this is, as you said, it's an extensive anterolateral MI. It indicates what? Proximal to D1 LED occlusion. Okay, ECG2. Somebody else?
طيب, a sinus rhythm with ST elevation in 1 AVL and even V2, V3, and also V5 and V6. There is some ST elevation, although it's one small square, and with reciprocal changes 3 and AVF.
Exactly. So what's your diagnosis?
Also extensive anterior lateral MI.
You know, if you look at the ST segment here, it's not even 1 millimeter in V4, V5, or V6. Maybe there's some other acute T wave, but this is what I just mentioned. When you see that there's AVL and V2 ST elevation, it indicates what? High lateral?
High lateral, yes.
Infarct. Yeah. Okay, because there's no significant changes in V4, V5. This is a high lateral MI, and it's due to D1 occlusion. 3.
Yes, there is ST elevation in V2, V3, and V4. There is ST elevation also in lead 1 and AVL. ST depression in lead 3 and lead 2. I think this is again extensive anterolateral. Sorry, anterolateral. Yes.
This is an anteroseptal MI. Okay, as you know, I brought this ECG mainly so that you comment on the hyperacute T wave. Look at the T wave; it's almost bigger than it's bigger than the R wave and almost bigger than the S wave. Usually, the T wave is rarely more than 10 millimeters. If you count here, it's more than 10 millimeters in almost all the leads, or it's more than the R wave. And this is hyperacute anteroseptal myocardial infarction. 4. Anyone? Forget about the BBC. Look at the ECG. What do you see? I've just mentioned that.
Is this
Hyperacute T wave, Doctor.
Exactly. There's hyperacute T wave where?
And
Which
lead V2, V3 mainly.
V2, V3, exactly.
And
But
there is
again,
V4.
exactly. There's in V4, there's in V6, because always take it in relation to the R wave. Look at the T wave in V5 in relation to the R wave. It's almost as big or more than the R wave. It's not an absolute number. It's in relation to the R wave. And again, you find that there's hyperacute T wave here. And there's also BVCs and BACs. This indicates that the myocardium is irritated and there's a high risk of arrhythmia. Usually the T wave persists for 30 minutes and then maximum, of course, it's usually 5 minutes to 30 minutes, then it proceeds to ST elevation. Okay, and I think we'll go to ECG 6. You know, this ECG, usually the hyperacute T wave is asymmetrical. What you see here is symmetrical, but again, it could be due to myocardial infarction. But here you have to rule out, as we discussed before, hyperkalemia, where the T wave is peaked. It's like as if it's pulled up. This most likely, this is hyperkalemia, but the differential diagnosis is always early revitalization, LVH, and acute myocarditis. Okay, ECG 6.
There's this elevation for V2, V3 with the Q waves. So V4 and 5. So this is one-way AVL, extensive also anterolateral with reciprocal changes.
Okay, so this is most likely again LAD proximal to D1. What about this? What do we call this pattern of ECG? Tombstone, شاهد حق القبور. And this indicates an extensive MI. It's an extensive anterolateral myocardial infarction. Okay, 8.
ST elevation في inferior lateral leads with hyperacute T wave في فهي inferior lateral maybe type 3 LAD.
Yeah, you know, the best way is to take the ECG lead by lead. Lead 1, there is nothing. Lead 2, there is a ST elevation. 3, there is a ST elevation. AVF, there is a ST elevation. AVL, there is depression. AVR, it's equivocal. Then V1, what do you see here?
Hyperacute T wave
Exactly.
with the ST elevation.
Yes, again, V2, V3, V4, and some in V5. So what do you call this? This is, as you said, type 3 LAD. Okay, what about ECG 9?
This is ST elevation in V1, V2, V3 with right bundle branch block, and ST depression in lead 2, 3 AVF.
What about lead 1 and AVL?
Lead 1 and AVL, There is ST elevation also in 1 and AVL.
Okay, and AVR.
Uh,
As I said, take always look at the ECG, take them lead by lead, okay?
yeah, there is ST elevation in AVR also.
Okay, so 1, there's ST elevation, AVL, there's some ST elevation or hyperacute T wave, AVR, there's ST elevation, 2, 3, AVF, there's depression, which is reciprocal changes. And from V1 to almost V4, there's ST elevation. As you said, this is anterolateral MI with right bundle branch block, left anterior sacral block. So it means it's a proximal or OCL LAD occlusion. ECG 10. This is the easy one.
Like ST elevation and 2, 3, and even AVF. With depression in 1 AVL and V2. As we mentioned, the elevation in 3 more than 2, so which with depression in lead 1, so it's going with RCA rather than LCX.
Okay, what about V1 and V2? You always forget the hyperacute T wave, all of you. Again, remember I always say AVL is a mirror image of lead 3. Look at it. What about V1 and V2?
Regarding the
Exactly. This is very important. You have always to look, anything you don't look for, you will not see it. Okay, there is isoelectric in V1 and ST depression in V2. R to S is almost more than 1. Okay.
Yeah. Mm-hmm.
All right. This, of course, this could be RBMI or it could be posterior MI. Because anyway, R to S is more than 1, almost more than 1, and there is ST depression. What about 11?
Sharp fin or lambda sign.
Exactly. And it indicates what?
Cute. I mean,
Where is the ST elevation, by the way? 2, 3, AVF, V5, V6, and the reciprocal changes.
and 1 AVL with the V2. V3,
Okay,
yeah.
ST depression in V1, V2, V3.
Yeah.
Okay, so it's a large high risk. It's involving almost everything. It's inferolateral STEMI plus query RVMI because V1 and V2 there is ST depression, isn't it? Let's
Yes.
go back and look. The R wave is less than the S wave, so it's most likely RV rather than posterior MI. So it's inferolateral MI with RV extension. Okay, what about the ECG? It's an easy one. Start from lead 1. Always look at start from lead 1. What do you see in lead 1?
ST
There is ST
elevation.
elevation.
Okay, lead 2 and 3 and AVF.
There is ST depression.
And
ST
lead
elevation
AVL. Exactly. So look, now go to the chest leads. V1, V2.
There is ST depression from V1 to V3.
Is the R wave higher than? Okay.
Yeah, R wave is more than the S wave in V3, and I think it is the same in V2. I'm not sure. صراحة.
Of course, we always look at V2, but this is more of, it seems that there is an LVH. So what we see here is that there's ST elevation in 1 and AVL with reciprocal changes, and this is high lateral STEMI. There may be some, anterior ischemia because diagonal sometimes supplies the anterior wall. What about 13? Start always with lead 1, sorry.
there is ST elevation lead 1 and lead 2 and lead 3 also AVF, and ST depression from V1 to V4 and ST elevation V5 and V6.
Okay.
Uh,
What about V2? What's the R to S?
more than one tall R wave.
Okay. So
I think this is
inferior, lateral, posterior. So it's involving, because there's one V5, V6. This is lateral. There is the inferior. And again, usually you should see reciprocal changes in AVL. You don't see it here because it became isoelectric because of the inferior ischemia. It's like a reciprocal change. Again, you see ST depression in V1, V2 with R to S ratio more than 1. So this is posterior. So we have lateral, we have posterior, and we have inferior MI. Okay, so this, again, because 2 and 3 are almost the same, or 2 more than 3, it's CIRC more than RCA. Okay, what about this ECG?
okay. I think there is ST elevation from lead 1 and ST depression lead 3 and AVF, ST elevation AVL, and QS pattern from V1 to V4.
Okay,
I
so
think
yes, go ahead.
it's high lateral MI.
Exactly. With what? Why we have Q here?
Old anterior MI.
Mumtaz. See, you know, the ECG interpretation is easy as long as you know what you are looking for and you know how to interpret that. So this is most likely high lateral MI with old anterior MI. 15.
Yes, doctor. There is ST elevation in V1, V2, V3, V4, V5 with Q wave, and ST depression in 2, 3 AVF. This going with the acute anterolateral, acute anterior MI.
So this is an extensive anterior MI. Okay. All right. What about this ECG? Sorry, let's go back to this ECG. What do you see here in the last one? The last QRS segment.
This
What do we
is
call this?
R on T pattern,
Exactly. This is an R&T and it indicates a high risk of
arrhythmias.
Yeah. Okay. 16.
Okay, there is a biphasic Dr. T wave in V1, V2, V3.
So what do you think is this?
It's Willen Dr. type A.
أعد النظر مرة أخرى إلى V1. What do you see من بداية ال QRS? What do you see? Is there an R wave in V1, V2, V3, V4? Q wave. Okay.
No. Yes.
When you see this ECG, it indicates most likely what? It's good to think of Wellens, but Wellens usually you don't see a Q wave in these leads. You will find a usual pattern. So this is most likely what?
Recent.
Or exactly, or LV aneurysm, because you see that the residual ST elevation in the anterior leads. 17. Again, start from lead one. What do we have? Where's the most prominent changes?
طيب 2, 3, and AVF ST elevation with
Excellent.
ST depression in 1 and AVL. And also there is a ST elevation in the chest leads from almost all the chest leads, V1, V2, V3, till V4.
Okay. What about the ST elevation in 3 is more than 2?
More than 2,
What-
so it's going with ST depression in lead 1, which is going
Yeah.
with RCA.
Exactly. What does the ST elevation in V1, V2 indicates usually?
The elevation in V1, V2,
September.
the left main.
لا. With inferior MI, what do you expect? Sorry?
RV infarction.
Exactly, RVMI. RVMI may be ST elevation and it could be sometimes ST depression. That's why you have to look for both. It may be isoelectric, it may be ST elevation, it may be ST depression. So any ECG changes, you may find it in patients with RVMI. The typical is ST elevation, but sometimes you don't see it. You see the ST depression. That's why we do the right chest leads. Okay, so this is, again, this is an example where you see ST elevation in V1 and V2, and it's an RBMI with inferior wall MI. Okay, what about the ECG? This is a very easy one, yeah. واضح.
So we have ST elevation in lead 1 and AVL, V2, V3, V4, and also V5, V6, with ST segment depression in lead 3 and AVF.
So what's your
So
diagnosis?
we have this is an anterolateral myocardial infarction.
Where is the lesion, you think?
This is LAD lesion.
Where? As we said, once you see one and AVL, this is what? Proximal LAD to D1.
Proximal LAD. Yes. Proximal.
And you know, the definition of proximal LAD is different between trials and between experts. For us, proximal LAD is before first septal. This is a proximal LAD.
Yes.
If the occlusion is before the first septal, then you will find ST elevation in AVR. If it's after the first septal, but before the diagonal, then you will find the anterolateral ST elevation. طبعا in ostial, you will find anterolateral plus AVR. If the AVR is not there, as here, then most likely it's after the first septal. Of course, this is not 100% accurate because
Yes.
you know, collateral blood flow and so on. Okay. 19.
Here we have elevation in lead 2, 3, with ST segment lead 2, 3, and AVF, with ST segment depression in from V1 up to V3.
Yani V3 is not really prominent if you look, not that significant, but V1 and V2 is significant. And
Deep ST segment depression. Also, we have elevation in V5 and V6.
okay. And whenever you see ST depression with inferior leads in V1 and V2, what do you look for immediately? The R wave.
The R wave, yes. You will see the R wave in relation to S.
Exactly.
Here, R wave is more than more than 1 in relation to S. So we have inferior posterior MI.
Exactly. And ST elevation in 2 and 3 are almost equal. So, or 2 is more than lead 3. This goes with what? Which artery?
CX.
So, okay, it goes with proximal circle. As you said, there's some lateral involvement because it's the circle. 20.
Yes, doctor, there's ST depression with the hyperacute, with the T wave elevation, V2, V3, V4, V5. I think this is going with D winter.
Okay. So let's take it one by one again. What do you see in V1 and V to V3?
ST depression.
Okay, ST depression. All right. And the R?
R is dominant in V2.
V2. You know, I'm showing this because this is a subtle inferior posterior lemma. Look at V3 and AVF. There's some ST elevation, isn't it?
Yeah. Yes.
Okay.
Yes.
And again, the T wave is upright in V1, V2. Sorry, in V2. All of these changes indicates what? Posterior wall MI. Okay, and when you say Williams syndrome, you have to see it in almost the other leads. You don't see anything in the other leads. While here, it's a dominant R in V2. So the transition is lost. Okay, usually transition occur where? In V3, the R wave transition. While here, if somebody comes with chest pain, these are subtle changes you have to be aware of when you look at the ECG. So this is a posterior wall MI, isolated posterior MI, where it's, you have always to do the posterior leads. That's why the guidelines recommend doing additional leads in patients with non-diagnostic ECG like this. And when you do the posterior leads, look what you see. There is ST elevation, V7, V8, and V9. So this is a posterior ST elevation MI. 21. يعني واضحة لأنك when you look at the right side of the ECG.
خلاص.
Okay. ST elevation lead 2, 3 AVF, ST depression lead 1 AVL, and V2 and right lead V4 is ST elevation. I think this is inferior and posterior with RP extension.
Exactly, excellent. You know, you see here there's an isoelectric with ST depression. So this is most likely RV extension. Remember the RV, the other one we saw was ST elevation. This is another example where you see isoelectric. Sometimes you will see ST depression in V1 more than V2, but the differentiation is the R wave. If it's posterior, you will see the R wave prominent in V2. If it's RV, the R wave will not be prominent as you mentioned. And the site of occlusion is where usually? This is approximate. Once you have RV involvement, it means the RV branch or the marginal branch is involved. And usually it comes at the middle of the RCA, or so it's most likely proximal to that. So it's a proximal RCA involvement. Okay, what about this ECG? Oh, هذه طلعت الكلام خلاص. Okay, anyway, in this ECG, you will find that there's Q wave in the inferior leads. I brought this ECG to show you what you see. This is what looks like a right bundle branch block pattern. But usually in right bundle, the R dash is smaller, is bigger than the initial R. Here it's the opposite. And in V2, you will see a prominent R wave. So this is most likely
posterior.
Exactly, it's a posterior, exactly, posterior in mind. What's going on? Why all the ECG is showing? Okay. Anyway, this is a Cabrera sign, and since you saw it, and you see that there is notching of the ascending limb of the S wave. Okay, let's look at this ECG. Of course, here there's no signs of ischemia, as you see. There's no concordant or disconcordant ST depression. We have only one criteria, which is more than 5 millimeters, but this is only 2, so it does not count. You need more than 3. Okay, what about this ECG? When you look at the ECG, what do you see? The most prominent is what? What is this? The spike here is what?
Base rhythm.
Facing.
Base rhythm, exactly. So it's a left bundle branch block pattern. Okay. Lead 1, do you see anything? It's normal as left bundle. What about lead 2? Lead 3?
ST elevation lead 2, 3 AVF and ST depression AVL. But I think also V5 and V6 there is ST elevation which is concordant with the QRS. Scarbosa should be positive here.
Exactly. So what you see here is a base rhythm with concordant ST elevation in 2, 3 AVF. So it's an inferior wall myocardial infarction. Again, you see ST depression, which is concordant in V1, V2, V3. It should not be this way, isn't it? It's concordant. Okay. And there's ST elevation in V5, V6. Okay. This concordance means what? Posterior MI. So it's most likely an inferior posterior MI. So again, even if you have base rhythm, you can diagnose MI, but you need the imagination and you need to see more and more ECGs. So you see that there's ST elevation, 2, 3 AVF, V5, V6, ST depression, V2, V1, V2, V3 goes with posterior. Okay, so it's inferior posterior lateral MI. What about this ECG? Start from lead 1, always. Look at lead 1. What do you see?
ST elevation lead 1.
Don't be distracted with the arrhythmias. Look at the normal QRS. Lead 1, what do you see?
ST elevation for first beat.
Okay, lead 2, there's nothing. Lead 3, what do you see?
Depression, ST depression.
ST depression. AVF?
Depression also, yeah.
AVF?
So is this high lateral MI with
Exactly.
With PVC.
With BVCs. But usually, you know, once you see the BVC, you will be distracted from the actual changes of the MI. Okay. What about this ECG?
This is based rhythm.
Again, start from lead 1. Is there any concordant or discordant significant ECG changes? 1, there is, or there isn't?
No.
2, 3, no.
Insignificant, no.
AVF, no. AVL, no. V1?
Best for V2, V3, there is
Exactly.
concordance.
Exactly.
I mean,
so
this is posterior.
Exactly. This is posterior with left bundle with base rhythm or a left bundle branch block pattern. What about this ECG?
LBB.
Yes. Is there any signs of ischemia anywhere? Scarbosa criteria, are they positive? Well, let's take them one by one. Lead 1, nothing. Lead 2, nothing. Lead 3, AVF, AV, all of them. V1, okay, it's all discordant and it's appropriate discordance. So here there's no evidence of ischemia. Okay, what about this ECG?
في prominent R wave و ST depression في V2 V3.
So it goes with what? What do you think?
With posterior.
Excellent. See, you know, posterior MI is the most difficult to diagnose when it's isolated. So it needs high suspicion. We will not consider this an innocent finding or just we ignore it. This is a posterior MI as you said. Excellent. Okay. 29.
ST elevation في الانفيريور مع reciprocal في ال 1 AVL. يعني يعني slight ST elevation في الانفيريور مع ST depression في ال 1 AVL.
So what do you think is this?
inferior. Inferior.
Excellent. You know, what we discussed earlier, AVL is almost 90% specific for inferior wall MI and subtle inferior wall MI. Okay, once you see ST depression in AVL with subtle changes that are not convincing, if you look at 3, it's not convincing. AVF is not really convincing, and 3 is not convincing, but this is documented inferior wall MI. Okay, so always be aware of AVL. Always AVL is a very important lead like V1. Okay, 30. Remember قلت لكم شوفوا الويب هذه you will not forget it.
The winters.
the winter. هاي.
Exactly. هذه ويب ما تنسوها يعني أول ما تشوفها تعرف what's going on. So this is a dew winter as you said, and it indicates what?
Proximal LED.
You treat it like what?
STEMI equivalent.
Team equivalent.
Exactly, it's a STEMI equivalent. Okay, let's look at 31.
Bilateral.
Bilateral.
Exactly, this is a high lateral in mine. شوف الآن you started easily spotting difficult ECGs, الهاي lateral, posterior, RVMI, and left bundle branch block, rare ECGs. ECG is always a practice. ترى بعد شهرين حنعيد ECGs هذه مرة ثانية واشوف ايش تذكروا منها. Okay, 32.
ST elevation from V2 to V4. I think this is anterior MI.
بس
With slight ST depression in lead 3 and AVF. لا lead 1 I'm not sure الصراحة about it.
Okay.
I think this one anterior MI.
Okay, what about V1? Why do we have that prominent R wave in V1?
RBB.
Exactly, this is right bundle branch block. Most likely it's new. What do you see before the R wave in V1 and V2? ايش الويف الصغيرة هذه اللي قبلهم؟
Q wave.
Q wave. Do you usually see Q wave in right bundle in these leads?
No.
You don't. Okay. So this is, as you say, this is right bundle, and as we said, right bundle does not interfere with the diagnosis of myocardial infarction. This is most likely an LAD occlusion, proximal, and with extensive MI. Once you see right bundle, it's either left main or proximal LED. 33. الاي سي جي هذه ايش؟ ساينس ريزم؟
Left bundle.
left bundle. Is there any positive scarboza? Once you see left bundle على طول you think of scarboza, modified scarboza. Is there any modified or non-modified scarboza? يعني الأوريجينال scarboza أو المodified. Is there any of them?
No.
Okay,
No.
there isn't. Is there any? What are the other signs you look for for left bundle? It indicates usually an old MI may occur with new MI, but it's not sensitive. ايش هذه؟
Cabrera sign.
Cabrera sign. And what is this? N1, AVL, and V6. What do we call it? The notching of the ascending limb of the R wave and the notching of the ascending limb of the S wave. R wave is called Chapman.
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 And this one is called Cabrera sign. Okay. اوكي هذا طلعت طلعت الدياجنوسيس. اوكي what about this ECG؟ يلا somebody reads it. Forget about what you see here. Read it for me please. Why we said this is a subtle inferior volume mine?
There is posterior also.
Exactly, there's also posterior, you are right. So why did we say this is subtle?
في ST elevation في الانفيريور leads with reciprocal يعني في شوية ST depression في ال AVL.
Exactly. So always AVL is very important. Okay. What about this?
There's ST elevation. There's ST elevation and lead 2, 3 AVF and 3 more than 2 with ST depression and 1 AVL and V2, V4R ST elevation. This inferior posterior with RV infarction.
Okay, again, you know, why posterior?
Inferior with RV infarction.
Exactly. So the R wave in V2
R
is
wave,
not there.
yes, yes.
Okay, this is another example. Again, as you see, there's no ST elevation, but there is isoelectric line with ST depression in V2. There's no prominent R wave. So this is, as you said, inferior MI with right-sided RV involvement. Okay, what about this ECG?
There is
Airway.
Whelan syndrome, this one, type 2.
قلنا في كيو ويفز.
PQS
يعني شوف هذه ترى هذه almost نفس الاي سي جي اللي قبلها.
aneurysm.
This is a fully evolved anterior volume eye with most likely aneurysm. Okay, يعني هذه ظهرت. What about this ECG?
هذه inferior with
Airway.
RV function.
Okay. And there is also arrhythmia, as you see. Okay. 40.
inferior posterior يا معلم.
inferior posterior معي حلوة خلاص حقبلها كذا بدون نقاش. Again, you know, لاحظ الاي سي جي V2 إذا قلبتها هتعطيك الريل بيكتشر. هذا الويلنز اللي دائما يقول ويلنز. This is a Wellens syndrome. Do you see a Q wave? Even in V1, you see a small R. Okay, and the biphasic T wave is all over. Okay, this is another example. Okay, here actually you see both. You see type A and here almost type B. This is a type B where you see there's no biphasic T wave. It's only inverted T wave, which is almost symmetrical. Okay. What do you think is this? And I'm sorry, لكن ما الاي سي جي طلعت المفروض ما يطلع الكلام لكن this is what?
Pericarditis.
This is pericarditis, exactly. ايش اكثر شيء we have to look for?
PR depression.
Exactly. لا أهم شيء to differentiate from ischemia is you see reciprocal changes. Exactly. You will not see reciprocal changes. يعني if you look at the ECG في V2, V3, it's very prominent الحقيقة. يعني it's significant ST elevation which usually you don't see في pericarditis. But what differentiated here is ما في ST depression في ABL. Okay. ما في reciprocal changes في the other leads. If you see ST depression in AVL, okay, then this is most likely ischemia. The only two leads that could show ST, the lead that could show ST depression is AVR. Okay. Thank you. Maybe we have to, maybe in some other time we have to repeat a different ECG course, and we'll just concentrate on the MI.
Thank you so much.
شكرا
عن الانيشال مانجمنت اوف ST. الله يعطيك. حتكون على الانيشال مانجمنت. طبعا حنتكلم عن الانتي بليتلتس، عن البري تريتمنت، عن الهيبارين. Then probably the lecture after we'll talk about primary BCI with whatever treatment with it as antiplatelets or whatever, then fibrinolytic treatment, and then the lecture after we'll talk about taking the patient to the cath lab after fibrinolytic therapy and the evidence from trials, the difference between facilitated PCI and pharmaco-invasive. I think the long-term treatment, you know, it's like ischemic cardiomyopathy. We'll not come across that. When we finish, probably we'll go to the non-ST elevation MI إن شاء الله. في أي سؤال؟
شكرا دكتور، يعطيك العافية.
ولكم. تبغوا الإي سي جي هذه ولا تخلوها as a quiz always؟
أي واحدة ECG دكتور؟
لا الإي سي جيز كلها يعني.
اللي حليناها؟
يس.
إيه ممكن ناخذها إذا سمحت.
عبير أنت صح؟
لا.
لا هاي طيب يعني أنت بتغشي عليها. خلاص ولا يهمك إن شاء الله. I will.
لا تقصد for next time؟ لا تعطينا إياها، خليها
يعني لأنه شوفي let me tell you believe me، شوفي الإي سي جيز هذه ترى احنا حلينا نصها المرة اللي راحت صح؟
إيه.
The first half after a month you will forget.
بعد ما نخلص طيب خلاص بعد ما نخلص
exactly. The good thing is that when you repeat it after a month and after 2 months it will eventually stick in your mind. So inshallah after 2 or 3 sessions I'll give it to you.
إيه إن شاء الله.
يلا
ونحتاج بعد complications of.
Sure. We'll talk about the complication of the mind. Actually, let me show you the folder of MI. Just a second. I will share it with you. Then we can. Why it's. Okay, let's close this first. You know, ST elevation MI is really, let me stop sharing, then I will share again. Do you see it? Why it's not showing with me? Do you see the, you should you see the list?
Yeah.
Okay, this is the ST elevation. It goes from diagnosis, initial management, procedural aspect, antiplatelets, RV لوحده, cardiac arrest لوحده, acute heart failure and cardiogenic shock, complications, pericardial complication, arrhythmias, management during hospitalization and after discharge, long-term dual antiplatelet therapy, medical management, CABG in these patients, MI with normal coronaries, MI in pregnancy, and when somebody has failure of thrombolytic or suboptimal perfusion, and finally transient MI. ST elevation MI هو تقريبا 80% من الكارديولوجي.
Whole chapter, yeah.
Exactly. So probably we have to come across all of this. It's a long subject, but once inshallah you know it and master it, يعني you will be excellent, and you inshallah you will be able to pass any exam بإذن الله عز وجل. So we will discuss all of these issues, which covers all aspects of myocardial infarctions inshallah. احنا الآن وصلنا إلى ما زلنا ترى في الdiagnosis، يعني احنا